I'm Dr. Melanie Hoppers. I'm internal medicine and pediatrics trained. I work in Tennessee in a rural environment, but I also work at the Bateman Horn Center. I'm located in both places, but I work for the Bateman Horn Center there in Salt Lake City, and I see both adults and children with ME/CFS, infection-associated chronic conditions, and long COVID. So I don't have any disclosures to discuss, and we don't receive any financial or other benefit from inclusion of any products, services, or companies. We're a 501(c)(3) nonprofit organization, and we focus upon clinical care, research, and education regarding infection-associated chronic conditions. So I want to talk to you about long COVID. I am curious how many people see patients. You see patients with long COVID. I guess my question is how many of you treat patients with long COVID? And if you get a chance to put that in the chat, I'd love to know. So long COVID is an infection-associated chronic condition. It's broadly defined as signs, symptoms, and conditions that continue or develop after initial COVID-19 infection. They must be present for at least 3 months as either a continuous relapsing and remitting or a progressive disease state. It includes a wide range of symptoms that may include any organ system, as well as different conditions that may be diagnosed alongside with it, including but not limited to cognitive impairment, forms of dysautonomia, mast cell activation syndrome, connective tissue diseases, and autoimmune diseases. So long COVID can occur after a severe infection, but really more commonly, it's after a mild or even asymptomatic infection. Additionally, a positive COVID test is not required for diagnosis. A lot of times, kids especially don't have a positive test. It's not as sensitive in kids. And, people just aren't testing as much anymore. And I lament that because it's helpful for long COVID. It's a little more validating in a way if you have that. Long COVID can start with persistence of symptoms with the acute infection, or confusingly can occur months after the apparent recovery. Sometimes you have to kind of remind the patient or the parent, think back. I've had patients looking on their phone for text. When did I have COVID? And they can find something in a text. Or a family member was sick because they may not have been sick enough to go to the doctor. Sometimes they aren't even aware that they had an infection. So there's that as well. Long COVID can affect any demographic. It can worsen pre-existing conditions, but can also lead to new conditions. Symptoms can vary in severity and duration, and is diagnosed clinically as there's no biomarker available. So long COVID is estimated to affect up to 5.8 million children and adolescents in the U.S. For comparison, there are 4.6 million children and adolescents in the U.S. with asthma. And I know you're treating asthma, right? So you're also seeing patients with long COVID. A disease is considered rare in the U.S. when it affects less than 200,000 individuals. 10 to 20% of children and adolescents develop long COVID after an acute infection. There was one study that showed a third of pediatric patients with long COVID continued to have symptoms at 12 months. And then there was a later study that showed persistent symptoms in some patients at 36 months. Risk factors include infection with pre-Omicron variant, increasing age of the patient. There's a sharp increase at the age of 12. There's also increased incidence in patients with higher severity of acute illness and number of organ systems involved, underlying chronic illness, and increased weight status. And although not well studied, social drivers of health, such as housing and food insecurity, are likely to be associated with increased risk. So just bear that in mind as well. So any organ system can be affected. And as you've probably read and seen, there's, 200 or more symptoms have been identified. I won't read all of these to you, but the list here in this JAMA article talks about the more common symptoms, and it's very, very much tracks with what I see in my clinic. Fatigue and malaise are big complaints, shortness of breath, dyspnea, headaches, dysautonomia, problems with concentration, and brain fog. Often they have GI symptoms. This can be in the form of diarrhea, constipation. They can go back and forth with that. They may have bloating, abdominal pain. There's a lot of nausea as well. Patients have a lot of infections, rashes, allergies, muscle and joint pains, and back pain. Sleep issues are also predominant. Some patients have hypersomnolence. I have one patient that will sleep for 24 hours at a time. Also, some patients have insomnia. Some have both. However, they all seem to have unrefreshing sleep. They can sleep that 12 hours, 24 hours, and wake up feeling exhausted. So infection-associated chronic illnesses aren't new. They've been described as far back as 1890-91 flu pandemic. Many different infectious agents have been associated with prolonged illness. EBV, West Nile virus, enteroviruses, Giardia, Borrelia burgdorferi. There's a subset of patients, however, with more severe and persistent symptoms. These can be further categorized as having myalgic encephalomyelitis chronic fatigue syndrome, also known as ME/CFS. So, what exactly is ME/CFS? It's a chronic, complex, multisystem illness. It's characterized by peripheral and central nervous system involvement, immune system dysfunction, a dysfunctional circulatory system, and impaired cellular metabolism. So the way we diagnose it, again, no biomarker. So we have clinical criteria. The major criteria, which they must have all of these, is that there's a substantial impairment of normal function, accompanied by fatigue that isn't alleviated by rest, and it lasts greater than 6 months. Also, they must have post-exertional malaise, and we'll talk briefly about that today, and non-restorative sleep. They must also have one of the minor criteria, and this is either cognitive impairment or orthostatic intolerance. I can tell you that in my patient group, almost all of them have both of those. So the health-related quality of life scores of children with ME/CFS are lower than those described for children with asthma, diabetes, epilepsy, and cystic fibrosis. It's a disabling illness. It accounts for a lot of school absences, and patients are sometimes even bedbound. So I wanted to quickly just tell you about this patient because I think it's very relevant. She's 20 years old. She became ill at the age of 10. She had infectious mono. She developed symptoms with her illness that never resolved. Fatigue, post-exertional malaise, hypersomnolence, headaches, and dizziness were some of her symptoms. So she has an infection-associated chronic condition. She met criteria for ME/CFS, although that wasn't diagnosed for quite some time. She received multiple workups, multiple referrals, subspecialty pediatric clinics. Her only diagnosis that she got was headaches and hypersomnolence. Internet searching, ultimately gave her a diagnosis of ME/CFS, also POTS, but there wasn't anybody in our rural area and even outlying areas that would see a patient her age with ME/CFS. There are very few providers for kids, and she went 8 years without a provider who knew how to manage her illness. So 8 years is too long. And, now we have so many more patients with long COVID, so many more patients with ME/CFS. We really have a healthcare crisis, and it really is going to require primary care to fill in this gap. So I'm really glad you all are here, and hopefully you're already treating these patients, but if you aren't, I hope you will consider doing so. So summary of the possible outcomes after a COVID-19 infection. As you can see, patient gets an acute illness. The majority of our patients do okay. 80 to 90% improve. 10 to 20%, however, develop long COVID. Of the long COVID group, again, some will go on to improve. Some have continued symptoms but don't meet ME/CFS criteria. And then there are those who do meet ME/CFS criteria. Unfortunately, I can't find any numbers for children as to how many who have long COVID meet this criteria. And it's not to say that patients with long COVID aren't sick. They are as well. This is just a sicker subset. And I treat them all. If a patient doesn't meet ME/CFS criteria, I still treat them and treat them very similarly. I just, want to kind of let you know about these patients as well. So how do I approach the patient? A comprehensive history, physical exam is mandatory, along with a symptom-focused diagnostic workup. We want to rule out alternative diagnosis. There is an increased risk of developing both type 1 and type 2 diabetes mellitus, as well as other autoimmune conditions in the first 6 months after a COVID-19 infection. And it's actually pretty high incidence of that. We also want to identify any possible comorbid conditions, as well as determine symptoms and their impact on patient function. Remember that children and adolescents describe things differently. We already know this, but these symptoms are kind of difficult to describe sometimes. I have adults who say, I don't know how to describe this. There's one symptom that is frequent, which is in adults, they'll describe this feeling of feeling like they're shaking on the inside. Well, how does a kid describe that? That's difficult. But when they say they have chest pain, they indeed may have chest pain, but they also may be trying to tell you they have tachycardia or palpitations. They may just say they need to lie down when they have orthostatic intolerance, and cognitive dysfunction may be represented by headache. So, just pay attention and see. Sometimes it's kind of hard to ferret out what they're trying to tell you. Your physical should include a detailed neurological exam and assessment for joint hypermobility. I have a lot of QR codes on my slides, and this one has a QR code for a form for that Biden score. 20 or 30% of patients with long COVID have hypermobility. So all patients you suspect of having long COVID should be assessed for orthostatic intolerance. There was a recent study conducted at the Kennedy Krieger Institute of 92 children and adolescents with long COVID, and 70% met criteria for an orthostatic condition. In adolescents with ME/CFS, it's almost 100%. So this is a condition we have precedents for treatment, and alleviating symptoms can help with quality of life. So I'm not happy that they have orthostatic intolerance, but it's something we can do something about. So that at least is good news. Orthostatic intolerance, I think y'all had a recent lecture, so I'll try not to be too redundant, but as orthostatic intolerance may also be known as OI. It's a group of conditions in which symptoms develop when assuming and maintaining an upright posture. This mostly refers to standing, but prolonged sitting can do it as well. And I often think about my kids sitting at school with their feet on the floor, and I worry about them. Many of these symptoms are relieved by lying down. So normally when a healthy person moves from supine to standing, you have a shift of blood, 10 to 15% pools in the lower extremity and abdomen. This causes a decrease in our central blood volume, stroke volume, cardiac output, and ultimately reduction in cerebral blood flow. So the normal adaptive response is to increase activity of the sympathetic nervous system. We get increased output of norepinephrine and epi. This causes an increase in our heart rate, increased cardiac contractility, constriction of those blood vessels, and this happens pretty uneventfully. Everything goes on as normal, and you never know anything happened. However, in patients with orthostatic intolerance, there's a maladaptive response. And there's multiple reasons for this, but three of the big ones is that there's a larger amount of blood pooling than normal. This may have some relation with their hypermobility, those that have that. Many, but not all patients have a baseline lowered blood volume, and their vessels don't respond well to the catecholamines. This results in symptoms. And so I kind of think of these as two categories. There's the ones that are caused by the cerebral hypoperfusion with headaches, brain fog, fatigue, impaired vision. They have exercise intolerance. But then the other symptoms are related to excess activation of the sympathetic nervous system, also known as the hyperadrenergic response. So you get these fight or flight symptoms with palpitations, tachycardia, shortness of breath, tremor, cold extremities, nausea. I've had many patients come in, they've been diagnosed, in the ER urgent care with panic attacks. And certainly it can look like a panic attack, but the difference being symptoms can improve when they lay down. Symptoms may be precipitated by standing up. It's also, associated with the brain fog. And so just, I guess my thought is if you're thinking of panic attack, at least consider orthostatic intolerance and run some questions by them and see if you think it might be that. So there are several types of orthostatic intolerance syndromes that are defined. They include orthostatic hypotension. This is a sustained blood pressure reduction of 20 millimeters of mercury or more systolic, or 10 millimeters of mercury or more diastolic within 3 minutes of upright posture. So this is more common in the elderly, but it can occur in kids. More commonly, we see delayed orthostatic hypotension. It's the same parameters, but after 3 minutes of being upright. POTS, or postural orthostatic tachycardia syndrome, there is defined as orthostatic symptoms along with an increase in heart rate of greater than 40 within 10 minutes of standing. There shouldn't be a substantial drop in blood pressure, and they should also have orthostatic symptoms greater than 3 months. Inappropriate sinus tachycardia is when a person has a heart rate of 100 beats per minute at rest and can often co-occur with POTS. Neurally mediated hypotension is related to excess parasympathetic tone. There's a reflex drop in blood pressure, and often patients will experience syncope. One of the ones I really want you to pay attention to, though, is this last one, low orthostatic tolerance. This is when patients have orthostatic symptoms, but without heart rate or blood pressure changes that meet criteria for any of these defined conditions. So these patients come in, they have symptoms, you test them, and there really isn't a lot of number changes, not a lot of objective findings. And we go, well, okay, you're okay, have a good day. But actually, this isn't what's going on. There's a group out of the Netherlands, Dr. Linda Van Kampen, and she worked with Peter Rowe, who is a physician at Johns Hopkins and runs the ME/CFS program for kids there. And they looked at cerebral blood flow in response to a heads-up tilt test in both healthy controls and people with ME/CFS. What they found was that when going from supine to a 70-degree tilt, healthy controls had a reduction in cerebral blood flow of about 7%. Patients with POTS had a reduction of 29%. Patients with orthostatic intolerance were 26%. But that low orthostatic tolerance group, the group without really significant changes, they had a reduction of 24%. So I think it's funny. The conclusion is, oh, wait, they do have symptoms. So what they were telling us all along is confirmed. And so, believe your patients. And I know most people do, but anyway. I've included a QR code for a questionnaire. It's 10 questions, and I can look at it and quickly see how affected they are. It's a great visual, but then, seeing the patient in person and asking the questions also, do you faint? Do you feel like you're going to faint when you stand up? How do you feel when you're taking a hot shower? A big one is, how do you feel when you're getting ready for school in the morning? That seems to be I call it the witching hour, right? That a lot of my patients don't do well during that time. Testing can be done in your office with a 10-minute passive stand test. Heads-up tilt test is great. I know in the Tennessee, I work I'm in Salt Lake City, but I'm also in rural Tennessee. We don't have tilt tests, so we can get it, but it may take 6 months. So you can do this in-office test. It's a Nasaline test. There's a QR code with exact instructions, but you have the patient. Heart rate and blood pressure are measured while they're lying down after 10 minutes of supine rest. Heart rate and blood pressure are then checked every minute for 10 minutes while the patient is leaning as pictured on the slide. We ask patients to be still, don't fidget, move around, try not to talk. This can alter the results of the test. So we also look for physical signs like acrocyanosis, delayed capillary refill, cool extremities. This is my patient, and that's what his legs look like. This is not just the coloring of the picture. He had purple legs. He has POTS, long COVID, and meets criteria for ME/CFS. But you can clearly see with his mom hand in the picture that how startling his legs looked. So management of OI addresses the problems with the physiology of the maladaptive response. And when practical, we want to avoid situations that bring on symptoms, prolonged standing or sitting with feet on the floor, exposure to heat. We also want to have them keep fluids available. There's a QR code with a beautiful list of school accommodations that I found online. It's from Standing Up to POTS. They're an organization, and they have this really good list of accommodations. You stick that in Chat GPT and you can get a letter real fast. So those are nice. You also sometimes have to advocate with parents. They're not experiencing the symptoms, so they may think, sometimes it's hard for them to understand. So just be sure to advocate with your patient in all the situations that you need to. We want to increase intravascular volume. We can do this with increased consumption of salt and fluids. Fluid alone won't work. You really need, you need the salt to bring that fluid back in. I start by recommending 2 liters of water a day. If you have a 80-pound 12-year-old versus a 17-year-old who's 6 foot tall and 180 pounds, is different amounts of fluid they can tolerate, right? So, but I start with 2, and then we see what's optimum for the patient. I recommend 3 to 4 grams of sodium per day. Several different ways of doing this, the electrolyte drink packets, table salt, buffered salt tabs, and just whatever combination works for the child. People have different things that they like, and whatever I can do to get them to get their salt. So now we have increased intravascular volume, but we want to keep it there. This can be achieved or helped with compression garments. These push blood back into the veins and assist the muscles to improve venous return. There was a study at Vanderbilt. They looked at patients with orthostatic intolerance and provided compression during a heads-up tilt test. And just time is limited, so I won't go through all the data, but the summary is that the greater the surface area compressed, the greater reduction in changes of heart rate, and there's preservation of that systolic blood pressure. Full leg compression up to the waist is best, abdominal compression next, and then the socks third. 20 to 30 millimeters of compression is recommended. Any higher, I really start to lose compliance, and I'm already having to beg them to do it anyway. Also, in patients with hypermobility, putting these on can be painful and cause injury even. So what else can we do to assess? There's different medications, fludrocortisone. This is a mineralocorticoid that mimics the action of aldosterone and helps the kidney to resorb sodium and water, thus increasing intravascular volume. It also has a mild vasoconstrictive effect. Headaches can occur though, lightheadedness. About 1 in 20 will develop a depressed mood, so you need to counsel patients prior to its use. Occasionally, I will use IV fluids. A liter of normal saline has 9 grams of salt. This can be helpful at the beginning of therapy to assist patients. A lot of them have nausea and trouble increasing that fluid and salt intake. So that's a lot of the times where I utilize this. Vasoconstrictors can be helpful. Midodrine is an alpha-1 agonist. It works to increase both arterial and venous tone. It helps raise systolic and diastolic blood pressures. It's especially useful for those who have flushing or problems with showering or problems standing. It can cause scalp tingling and itching, kind of a feeling of your hair standing on end. This does usually resolve within about a week or so, but if they can just hang in, it may be worth it for them. I don't use it with stimulants. This can cause too much blood pressure increase. Stimulants and SNRIs can both cause vasoconstriction. These two drugs I kind of use when I have another reason for it. So if you have a lot of cognitive issues and attention issues, and I'm already thinking about a stimulant and I can hit 2 birds with 1 stone, that's what I'm going to look for. Same with depression. So we can also address the excess catecholamine release. You can use beta blockers, first and second generation. Propranolol and metoprolol are often used. There was a study from Vanderbilt. They compared 20 milligrams versus 80 milligrams of propranolol, found the lower dose to be more effective at reducing symptoms. Just recall that decreased stroke volume and your heart rate is a way of compensating for that. So I kind of want to blunt the heart rate, but I'm not trying to just take them down to 60 and keep them there. That's not what we're trying to do. Beta blockers, of course, do lower blood pressure. So if the systolic is less than 90, I don't usually use it. Pyridostigmine increases parasympathetic activity and reduces heart rate, does have a lot of GI side effects. Ivabradine can lower heart rate without lowering blood pressure. Just be aware, as with all of these medications, this isn't really a pharmacology lecture. Be sure and do your due diligence and look at side effects and interactions and things. But ivabradine has some drug interactions you want to look at. Don't give it with Paxlovid. It can prolong the QT interval with that. Clonidine and guanfacine can be helpful. They help that sympathetic overdrive, can help with insomnia while lowering the heart rate. So I've sort of already mentioned most of these things, but I'll just add on, if they have headaches, a beta blocker is a good choice. If they have an exaggerated response of their heart rate to exercise, ivabradine is a good choice. So next, I want to talk about mast cell activation syndrome. And this is another one of those comorbidities we see a lot in infection-associated chronic conditions. The heightened incidence is likely due to a combination of prolonged immune activation, chronic inflammation, viral persistence, and the inherent sensitivity of mast cells to viral infections. All of these work together to perpetuate the hyperresponsiveness of mast cells, leading to a wide range of symptoms that we see in these patients. Mast cells are a type of white blood cell. They are located virtually in all tissues. They act as sentinels that patrol at the body's portal of entry, so our mucosal membranes, GI tract, GU tract, respiratory tract. Interestingly, though, mast cells are co-located with blood vessels, nerves, and connective tissues. This allows them to be strategically positioned to modulate sympathetic activity and vascular tone through various mediators. This may play an important role in orthostatic intolerance. Additionally, mast cells have stretch-sensitive chloride channels, and these can be activated with venous blood pooling from the stretching. So you can see how these two illnesses can interact and perpetuate each other. Treating one oftentimes requires treatment of the other. So there are two major categories of mast cell dysfunction. Mastocytosis is a clonal disorder that occurs when mast cells are overproduced. But what we're talking about is mast cell activation, where this is a group of disorders where mast cells are hyperresponsive. This leads to excess mast cell mediator release and episodic multisystem symptoms. So when mast cells are presented with a trigger or an allergen, they become activated. They release chemicals and mediators. These can be triggered by IgE, but also there are receptors, like I said earlier, for stretch. There's receptors for temperature and things like that as well. There are over 1,000 mediators that have been identified, so you can imagine this is why we have such a wide range of symptoms. Once activated, mast cells can send distress signals through the nervous and endocrine system and initiate a cascade response in distal areas of the body. So there are many triggers, and these are important to identify. Heat, cold, temperature changes can all trigger mast cells. Stress can activate mast cells, whether it's emotional stress, physical stress, such as pain, surgery. What happens is that there are receptors on the mast cell for corticotropin releasing hormones. So this is how stress can activate them. Mechanical irritation, pressure, friction, vibration. Think of, pressure with a waistband, things like that can trigger mast cell activation. Exercise, food and beverages are particularly common. Medications or their excipients can cause symptoms. I look at allergies, especially in adults. It's not so much in kids. They haven't been exposed to as many medications, but if you have somebody with 6 or 7 allergies, I start thinking about mast cell. Kids will have, a kid that comes in with 2 or 3 allergies, that's, you go, and that may be something to think about as well. Infections can trigger mast cells like COVID-19, sunlight, chemicals, tobacco smoke. So to diagnose mast cell activation syndrome, there is no specific criteria for kids. That makes things a little bit problematic. I looked around to see what everybody else does. The Mastocytosis Society suggests using adult criteria, and then there are some groups that's what they do in their research and such. So the first criteria for adults is episodic symptoms consistent with mast cell mediator release affecting 2 or more organ systems. When you look at the symptoms, it sounds like I'm reading you my long COVID list again. So a lot of those symptoms overlap. Oftentimes in kids, it's the skin and GI tract. So flushing, itching, rashes and hives, digestive symptoms, again, cramping, bloating, nausea, vomiting, diarrhea, constipation. And then, again, I won't read all of these to you, but kind of the same symptoms you saw with long COVID. Also, the second criteria is improvement after treatment. The third criteria includes elevation of validated urine or serum markers for mast cell activation. This is the one that's so hard. The tests are difficult to do properly. They have to be collected, transported, and processed in a particular way. They have to be collected, if it's blood, collected in a chilled tube. It has to be immediately put on ice. It has to be, frequently it goes somewhere across the country. It has to stay frozen. And then they have to centrifuge it in a refrigerated centrifuge, which many labs don't have. The first month or two, I was checking these in my own office, and guess what? We didn't get any positive because I was not doing them right. So I've learned from that. And if you are interested, we have something on our website with a QR code that gives you some instructions and actually a sheet for your patients to follow. I do the labs, even though frequently they're not positive, but I do them, and sometimes I do get positive labs, and it's helpful, it's nice to have some proof. It's also nice if you have a drug that you want a PA for, what have you. And I just think in general, it's nice to get the data. Patients don't have to be off antihistamines, but they should be off anti-inflammatory meds a couple of weeks before testing. So the picture on the left is just an example of dermatographism. You can check for this in your office with a tongue depressor. Just gently bring it across the skin, and you can watch for a wheal and flare response. The second picture is my patient who had a mast cell reaction subsequent to a stellate ganglion block. We thought it was the Band-Aid. It wasn't. We did another stellate ganglion block, no Band-Aids, and she still had the same rash. And so that was not the problem. Treatment for mast cell activation begins with identifying and avoiding triggers. Symptom diary can be helpful for this. Also, diamine oxidase. This is a supplement that helps to break down histamine in foods. I have a couple of patients it's been extremely effective in. I have one patient that completely quit seeing me because she got better with diamine oxidase. She emails me occasionally and tells me how great it is. But additionally, you can look at diet, trying to reduce histamines in the diet. I recommend reducing processed foods. I recommend that to everybody anyway, but reduce your processed foods. Sometimes in peds, milk can be an issue. So milk products, you might try reducing that to see if that improves their symptoms. So H1 and H2 blockade is the first step. Mostly I use non-sedating H1 blockers, but sometimes the sedating ones can be useful. Nighttime dosing with patients who have insomnia. Also, at low doses, the sedating H1 blockers can actually sometimes improve the brain fog and daytime somnolence. I didn't believe that at first, but Dr. Larry Afrin is one of the physicians who's involved in, he's the mast cell guru. And he told me this, and he said, it's because they cross the blood-brain barrier. So if you do it at low doses, oftentimes that works, and indeed it does. Also, it's not always the first one you try. You can try fexofenadine, get no response, and change to loratadine and see improvement. So if you don't get a response, then it's good to move on and try a different one. H2 blockers can provide a synergistic effect. That's when I don't try different ones. I stick with famotidine because I don't like the drug interactions and all the other problems with the other two. All of these come in liquids. Famotidine, no, I think you have to do a prescription to get the liquid, actually. Benadryl can be used if the patient's having flare, IV, IM. Now they have IV sertrazine as well that you can get. Mast cell stabilizers prevent the release of allergic mediators, but only when used on a regular basis. They don't provide relief in acute episodes. Cromolyn sodium is a mast cell stabilizer. There's multiple forms of it. You can get eye drops, nasal spray, and inhaled cromolyn for respiratory symptoms. Compounded oral cromolyn is helpful, especially for cognitive effects and migraines. The nasal spray, interestingly, and I got this piece of advice from Dr. Peter Rowe, is the nasal spray will sometimes help brain fog. So that's a pretty simple, benign thing to do to try. And that's a neat little trick that he taught me. Compounded ketotifen, this is a mast cell stabilizer as well as an antihistamine. You have to get it from the compounding pharmacy because we don't have it in the US. Quercetin, luteolin, there's a liquid formula. I like to use the low phenol formula. There's something called Neuroprotect LP, and I like that as well. So then we also have omalizumab. This is a monoclonal antibody. It's directed at the IgE molecule and down-regulates the receptors as well as stabilizes the mast cells. These can be somewhat hard to get the insurance to pay for, though. So I'm going to just do a quick introduction to post-exertional malaise. There's more of this coming later in a different lecture, but I think it's so important that I really want to talk about it. So post-exertional malaise is also referred to as PEM. It is defined as an inability to recover normally following exertion. It results in worsening of symptoms and functional ability. Most of the time when we think of exertion, we think of physical activity, but PEM can also be the result of cognitive, emotional, or social exertion, as well as exposure to environmental stimuli such as bright lights, sounds, and smells, anything that requires energy production. PEM can be immediate, but it's often delayed, occurring 12 to 72 hours after the exertional stressor. There is prolonged recovery out of proportion to the once tolerated trigger, sometimes taking days, weeks, or even months to recover. So, cardiopulmonary exercise testing has been used to investigate post-exertional malaise. CPET testing includes controls to ensure that results are not secondary to lack of effort or deconditioning. And what they have found is that in patients with ME/CFS and long COVID have a decrease in their peak VO2. This is a surrogate marker for peak exercise capacity. There is a lowered anaerobic threshold. So this is when the body converts from aerobic metabolism to the much less efficient anaerobic metabolism. This occurs much earlier in these patients. There's also decreased oxygen utilization by the tissues. There's a reduction in mitochondrial enzyme activity, damage to the muscle during post-exertional malaise, and patients have more highly fatigable muscle fibers. And I tell you all of this because so often patients, whether they're being told this by their friends, their family, their doctors, their nurse practitioners, the nurse that they're seeing, or whomever, that they're just not trying hard enough, or hopefully they aren't told this, but they may be told they're lazy or they're depressed. If you don't have mitochondria working correctly, you can't produce energy. If you can't produce energy, it doesn't matter how much you want to get up or how much you want to do things, you can't. So just a little bit of information so you know the basis for it. I do a whole talk on this, and obviously not time for that, but just that's the summary. That's the summary slide of that talk. This is just to give you a picture of post-exertional malaise in one of my patients, and she is happy for this to be shared. She wants people to understand more about her illness. She's 20 years old. She has a full-time college student. She was a full-time college student. She lived on campus with a part-time job, very active, happy, living life, doing great. She developed a COVID-19 infection, subsequently developed long COVID, met criteria for ME/CFS. She ultimately had to withdraw from school, come home. I began seeing her at this time, and we worked together for about a year, worked on her orthostatic intolerance. She had mast cell activation, and she was a great patient. She really, really paid attention. She's learned how to pace, and she was doing well. She had improvements. She was still homebound, able to do, go get coffee occasionally, maybe go to the bookstore. Wasn't super active, but she was able to enroll in online classes part-time. At the end of the semester, she wanted to go in and take her exams, as that's what was required of her. She didn't want any accommodations. She didn't want any help. So she went in and took her exams. She told me we talked about it a lot later. She said, I came home, felt okay, didn't feel great, but felt okay. She said, I was a little bit irritable, but fine otherwise. Ate dinner with family, watched a movie, went to bed. Next day, she didn't wake up till late afternoon. She said, I felt horrible. I woke up with a splitting headache, worst headache she can remember. She said, I felt like I had the flu. I had a little low-grade fever, sore throat, myalgias, arthralgias, everything kind of hurt. When she tried to sit up, go to the bathroom, felt dizzy pretty quickly, really struggled to get there. She was bedbound mostly for about a week. And it took her a month of not doing much of anything to return to her previously reduced baseline. This was an active, healthy, vibrant college student. So again, is this post-exertional malaise? So she had multiple types of exertion, cognitive as well as physical and social. She had a delay in her symptoms from the exertion. She had prolonged recovery from her symptoms, as well as worsening of her symptoms and functional decline. So that's what PIM looks like. It's not always this severe. Sometimes it's more severe. It kind of depends on your baseline. If you have a mild illness, then you may be able to do a bit more. Everyone sort of has this envelope of energy, what baseline symptoms they can do without experiencing PIM, and finding that baseline is really what's important in these patients. Repeated episodes of PIM or a particularly severe episode of PIM can result in worsening of an individual's baseline, and it can do so permanently. It has been postulated that the neurophysiological responses that take place in PIM may accrue over time and leave permanent injury to neuronal networks. And there have been studies to support these observations. In 2009, Dr. Leonard Jason, I believe from Chicago, conducted a study, and they provide nurse counseling to patients with ME/CFS regarding pacing of activities to prevent PIM. And at the end of the year, they divided these into two groups, those who were able to pace and successfully and those who were not. And what they found is that the patients who stayed within their energy envelope had significant improvements in physical functioning and fatigue, highlighting that this can be an effective tool for preventing PIM. So that leads me to tell you about Amy Mooney. She is a wonderful occupational therapist. She's in private practice. She's also affiliated with Bateman Horn Center, and she's going to talk on PIM and give you some strategies for helping your patients to prevent this. And it's a really important topic, and I hope you tune in for her.